what's the goal here? First, I want to say that all of these slides are going to be available after the conference online, because there are a lot of slides. And why I frame this a mini medical school is I'm not going to show videos and talk about macro trends. Well, I will talk about some macro trends. But my goal is to transfer to you a knowledge base to really understand the major trends in healthcare, the major trends in healthcare economics, so that when you go back to your institution or your work, or you work with healthcare clients, you'll really understand the major issues that if they're not dealing with, they need to deal with. So that's the goal. Any questions anytime? Okay, it's mini medical school. Raise your hand, and I'll be delighted to take them. All right, I'm not interested in giving a soliloquy. All right, so what we're going to talk about, as a physician, one of the first things you learn is you really want to keep people alive if that's what they wish. All right, that's like a basic thing, okay? So we should talk about life expectancy. I think you've heard a lot of very optimistic future ideas about longevity. I may actually dispel most of those today, okay? I don't think that's really going to get there. So we'll look at causes of death. We'll look at health disparities, which are huge. We'll look at chronic disease burden and how that plays into our economics, and thinking about how we function either as a health system or as an organization, especially an IT organization that serves them. I have to talk about Ebola virus, because if I don't, someone's going to ask me questions, okay? So I will educate you about that. And then we'll talk about access and really about the finances of healthcare and the finances of Medicare and Medicaid. Again, huge impact on health systems and going forward in the future as a country. All right, so what about life expectancy at birth? Now you can see that in 2010, the life expectancy is rising, but you see that white females live the longest, black females more than white males, and then African American males really have the shortest lifespan. And that actually, the differences are actually coming together, but it's still a huge tragedy for the United States. I think what people don't understand from a genetic basis is that the lifespan of Hispanic Americans is longer than white Americans or black Americans. Now, it actually matters where you live it matters what state you live in, to be more accurate, than how long you live. And you may say, oh no, that's because of genetics. That's because the folks who live in the South have higher rates of obesity, which is true. So maybe that's the factor. But the reality is, every year on Medicare, Minnesota and Wisconsin trade off as number 1 and number 2 on health outcomes and low cost. And the reality is that if you move to Texas or Louisiana, which has the worst health outcomes and the highest cost, you're really going to be disadvantaged. And when this was studied further in a very controlled way, correcting for all factors that have to do with health factors, income, and race. Why do we say income? Overwhelming evidence. If you're highly educated and you have a high income, you're going to live longer. I think we can all understand that, but that is a reality in the United States. But you see the biggest factor in your longevity and the care intensity that you need is where you live. Shocking, okay? This has been shown in areas throughout the US, and I think something that we often don't appreciate, and we're actually very fortunate to live in the upper Midwest, which has great outcomes and low cost. This just looks at 10 years and the changes in life expectancy, really actually death rates. And you can see there's been significant improvement in African American women and men, but has not caught up certainly to non-Hispanic white females and males. And here again is that Hispanic population who continue to have the lowest death rates in the United States. Yes?
Are these natural deaths, or do they also include accidents
They include accidents, and I'll show you that data. They include homicides as well. So great question, and I'll come to that in a little later in the talk and show you the data by age as well. So, and I think that issue gets to what are people dying from? I mean, again, if we're interested in healthcare, we want to understand longevity and death rates, and then we want to understand what are the etiologies, right? So if you look at men, you can see that we've made improvements in heart disease and stroke. Why? Because we have statins, we have other things that treat atherosclerosis. We do better at treating hypertension, and so we have had some benefit. We've reduced tobacco use, which has had an impact. And it's really parallel findings in women. And you see that heart disease and cancer are right together there. Here you see the diabetes and also the unintentional or injuries, which is in that blue right here. And we'll break this out in a finer way. So here's really gets to your question, okay? So you have to break the population out by age. So if you look between ages 1 and 24, obviously a relatively small number of deaths, but you know, in the World Health Organization, we'll look at years of life lost. And you're going to have the highest degree of years of life lost when you die as a 4-year-old versus die as a 94-year-old. I mean, that's self-evident. So that's a bigger impact on society from an economic productivity perspective. And I think it's quite remarkable. Accidents is the #1 cause of death before age 24, from 1 to 24. You go below 1 and you're into a whole other congenital disease area that we're not covering here. And homicide is #2 at 13%, and suicide is #3 at 13%. I mean, I find that really sobering, especially, fortunately, I guess I could say, all of my 4 kids have made it past 24, but you think about that from a parent perspective, boy, you really want to be aware of these issues. You move into the 25 to 44 years of age, accidents are still #1. And you think about this from a public health perspective of where we should be spending our dollars and what we should be doing. It's great we have airbags, it's great we have seatbelts, but still accidents are #1. And then now you see cancer and heart disease accounting for 1/4 of the deaths. And suicide is still 11%. So is almost as significant as cancer and cardiovascular disease up until ages 45. Now you get into aging, and you're nearing the baby boomer category. And now you see cancer is #1, heart disease as clearly #2. Accidents now are less. It's either folks don't drive as aggressively or they can't drive anymore, whichever. No, that's the next category. But you can see in chronic respiratory disease. So now it's really about cancer and heart disease and associated diseases. Over 65, so this is where, appropriately so, the largest number of deaths occur. And here you can see that heart disease is #1, cancer is #2, and then you see stroke being as important. Stroke is really a cardiovascular disease, and in some ways you should put it together with heart disease, which makes heart disease, cardiovascular disease, and cancer really the major causes. And now we see Alzheimer's disease, and we'll look at data on that as well, because this is going to become more and more important as lifespan increases. Tobacco use basically has decreased over the last 10 years, and that has caused great positive effect for cardiovascular disease, for respiratory disease, for lung cancer. There's a problem, and we'll come back to it. All of the health benefits that we have reaped as a society by taking action against tobacco, decreasing use of tobacco, we have lost by the increased rates of obesity. So here it is. And I just find this amazing when you actually see it this way. Here's the United States of America in 1990. There is no state that has a degree of obesity greater than 10 to 14%. And the white ones here at that point in time had no data. So remember that. No state in the United States was greater than 14%. You go to 2000, and now we have a large sector of states that are between 15 and 19%, And look at all these states in the southeastern and mid-America that are between 20 and 24% of their population is obese. Now, people will say different things. This is fast food. This is the food industry. This is putting fructose in everything that we eat. This is processed food. This is not cooking. Whatever the issues are, it's a huge, huge health tsunami coming forward now. And you look at 2010, and now you have a significant number of states with greater than 30%. What are the health outcomes of obesity? You get increased incidence of hypertension, you get increased incidence of cancer, you get increased incidence of diabetes, you get increased incidence of cardiovascular disease, you get increased incidence of liver disease. All of these are well established, okay? So this is, to me, honestly, forget about Ebola. This is the greatest public health issue that's facing not only the United States, but the world. And especially because of the incidence of diabetes. So here you can see the growing rate of diabetes in the United States. And you can look back in 1990, and you're talking about 2.5% of the population having diabetes, about 8 million people, and in 2009, you're up to almost 6.5% and greater than 20 million people. Kidney disease, kidney failure, yes? No, this is all diabetes. Good question, good question. This is all diabetes in the United States, and that's a great point. Type 1 diabetes is really, in some ways, it's usually a post-viral infection. It's an autoimmune disease. You destroy the cells that produce insulin. Type 2 diabetes, often associated with obesity, is a diabetes resistance disease. You cannot produce enough insulin, which is the hormone involved in metabolizing glucose in cells. You cannot produce enough to actually keep the glucose down and prevent the sequelae of diabetes, because you have diabetes, your cells are resistant to the normal physiologic effects of insulin. Now, what about cancer? We hear a lot of great things about cancer, and there have been some really great things done, but there is a reality check. So if you look at lung cancer, the incidence of lung cancer has gone down a little bit because of the reduction in tobacco. The deaths per 100,000 really, we have not made great progress in treating lung cancer. Colorectal cancer is really one of the great success stories because we have better screening. We talk about colonoscopy, et cetera. And so that is really, again, shows that screening and early diagnosis is what it's all about. When you look at breast cancer, the incidence of breast cancer actually is stable, certainly not going down, but the treatment of breast cancer has markedly improved. And part of that is the beginning of pharmacogenomics, where if someone has a HER2 positive type breast cancer, then that's an estrogen receptor, so you can use anti-estrogen therapy. So we're getting to that issue there where now some pharmacogenomic activity is actually having an impact on the outcome. Pancreatic cancer is becoming more common. Part of that is probably increased longevity, and basically this is a disease that we have no progress in whatsoever, because the disease is almost always diagnosed when it's no longer surgically resectable, and the only cure for pancreatic cancer at this point in time is a surgical cure. If we look at prostate cancer, a high incidence of disease, a low incidence, no, let me rephrase it. A high incidence of cancer cells in the prostate, a low incidence of disease, which is why there's good data that for men 65 and older, one should not actually check for prostate antigen, et cetera, because you are overwhelmingly more likely to die from something else other than prostate cancer. And the outcomes from prostate surgery, which is a very high incidence of impotence and a very high incidence of incontinence, is really a poor trade-off to just don't look, don't tell. Okay, nothing to do with Bill Clinton, but it's a don't look, don't tell. Leukemia is a very rare disease. We're doing better in treating leukemia, and it's getting better and better. Liver cancer is really much more endemic. Why? Because of the increased incidence of hepatitis B and hepatitis C. Both of those are sexually transmitted diseases. Both of those are blood-transmitted diseases. There is now actually therapy that's available for both Hep B and especially now for Hep C, some recent drugs that came out that happen to cost of the drug for 8 weeks is $84,000, which has been a little bit controversial, but it's very effective. But very high incidence of cirrhosis and then hepatocellular carcinoma. Any questions about cancer? Okay. All right, the population is aging, and it's a huge, so you think about obesity, and then, oh my God, now we're going to have a much older population, and everybody's going to live longer. And you're going to have higher burden of chronic disease. Huge impact on the health system, and you see numbers going from the 40 million to 2050 above 80 million, age 65 and over, and age 75 and over, hitting 50 million folks in the United States. Huge impact from a care perspective, huge challenge. And Alzheimer's, and there was some discussion about that in an earlier session. Currently, the incidence of Alzheimer's is about 5% for a population above age 65. And you see actually, this is actually numbers in millions. So you see 5 million, and you see this going up radically. The cost of, I'll get to you in a second, the cost of treating and managing an Alzheimer's patient is about 3 times the average patient that age. And the reality is there's still drugs and tests, but there is no effective treatment today. If you do a brain biopsy on patients with Alzheimer's, they have plaques of amyloid protein in their brain. And so the focus is on how do you reverse those plaques. And that's where the research is, but there is no effective treatment today for Alzheimer's. Yes, sir?
Can you go back one slide?
Absolutely.
What's the kink go ahead one slide?
In the aging?
Yeah, there's
Well, that's the baby boomers. So you're getting that first thrust of that new population of baby boomers. So baby boomers started in 1943, and so you're seeing here now you're just hitting that generation that comes in, and that is a bolus generation. All right, Ebola virus. Now I can do this as long or as short as you want, okay? And I had sent out a company-wide communication last Friday because I just happened to walk down the hall in one of our offices, and I overheard a conversation with a tremendous amount of fear and misinformation. And as soon as I started talking with folks and helping them understand it, everybody said, well, I want to hear this too, and so forth. So I said, okay, I have to send out a communication to the company. This was attached, but it wasn't the communication. So this virus has probably been around for a long time, but it was first discovered in Zaire in 1976. It's a family of hemorrhagic viruses that have been studied in different viruses for quite a long time in laboratories. These protective coverings that the virus have make it very difficult from an immune response perspective. So it really is a challenging organism to develop a vaccine. You only get the disease by having skin breaks in your skin or mucous membrane exposure to infected body fluids or blood from a symptomatic infected individual. And here's a list of all the well-documented body fluids that are Ebola positive. Now, there has been Ebola virus found on the skin of individuals who are suffering from highly symptomatic disease, but again, you're going to have various body secretions that are going to be on the skin, and it's going to dry and so forth. Ebola has never, ever, ever been documented to be transmitted by air, water, or commercial food sources. The reason that this is the worst outbreak that ever has occurred in recorded history since '76 is previous outbreaks have been largely in highly remote rural areas. This is the first outbreak that's occurring in highly populated, highly concentrated areas. in areas that also have very poor public health and very poor access to health care. The incubation period is 2 to 21 days, so this is this famous 21 days that you hear, where the 44 folks who first contacted the index case in Dallas got past the 21 days, so they're home free. Most commonly, and what does an incubation period mean? You get an infection. You can have an infection without having symptomatic disease. The incubation period is the time period between when you get infected and when you become symptomatic from a disease. Every infective organism has a different incubation period. If you look at HIV, other than the acute HIV setting, the incubation period for onset of AIDS was 7 to 10 years. So the disease presents really very nonspecifically: fever, muscle pain, malaise, which means you feel crappy, and diarrhea, which also makes you feel crappy. And so if you're anywhere in the United States, you're going to see tons of patients. The average American in the US, and I think most of us would agree, have 3 episodes of gastroenteritis per year. And that's always food related, and it's almost always more common to be eating out than eating at home, okay? But when you get rash and hemorrhagic shock and encephalopathy, which basically means your mental function is impaired, then that's obviously a much more serious disease. All of these are ways to diagnose the infection. The most effective one is PCR, because you can detect infection earlier. And I would say one of my own pet peeves is that if you have folks coming in to an airport from a high-risk area, for goodness sakes, don't take a temperature because they may have left 4 days after they got infected. Do a PCR and make them wait around for 3 hours till the PCR comes back, because the PCR will be positive even when you're not symptomatic and you are infected. And so it bugs me. I don't know why we're not doing that. Well, I don't know why we're not doing that. I think we should be doing that. So here's one of the up-to-date maps from the WHO as of September 14th. It was just published in the New England Journal of Medicine 3 days ago. And you can see the number of cases. When you add up all the cases, and I checked the CDC website this morning because my spouse Marcy said, you have to check everything. You have to be absolutely up to date on Ebola. And those of you who've met her would understand that. So far, there are about 10,000 cases and about 4,700 deaths. So this is a terrible human tragedy. The assistance that has been promised by France, Britain, and the US is still not really on the ground. This is still being managed by Medicine Without Borders, which is a French organization, which is very experienced with doing this. But the whole system is overwhelmed. Half of the 130 physicians in Liberia are dead, have lost their lives due to treating patients with Ebola. So it's a huge challenge. So the WHO estimates are by December 1st, there will be likely about 27,000 cases as a best case scenario, and as a worst case scenario, about 500,000 cases. Yes, Consuelo.
I say they, and I think we know who I'm talking about, because I don't know specifically when I say they, but it seems to me that this one particular doctor was right there, Dr. Bruce, who was in pictures of. What's the big deal with everyone saying, okay, we got to get a blood transfusion from that guy. Oh, we need to have him do whatever. I mean, they're making it sound like he's some super gene because he survived, but so did the other woman out there.
So actually, in the developed world, there have been 17 cases to date. In the United States, 4 have been successfully supported. There is no treatment. They've been successfully supported and discharged. 3 are still in the hospital. And there's been 1 death, which was that index patient who came in from Liberia. Spain had 3 patients, and 2 of the 3 died. The issue is there is a hypothesis that if you survive the infection, you are generating what are called neutralizing antibodies that will neutralize the virus, which is why you become viral free. So the question is, it's called passive immunization. Passive immunization is when you take a serum that contains presumed neutralizing antibodies and you give it to someone exposed to prevent the infection. However, and actually in the pre-antibiotic era, people used to treat pneumococcal pneumonia, which is easy to treat with penicillin or many other antibiotics, with so-called immune serum that contained antibodies. When I was a medical student and I got a needle stick in my hand from the blood, containing the blood of a patient who was hepatitis B, then I got what was called immune globulin, which contained anti-hepatitis B antibodies, and I didn't seroconvert. So passive immunization is 100 years old. However, we actually don't know if it works in this. So, and you can't get enough serum from one patient to treat 17 patients, much less 10,000 patients. So it is something that makes sense, but it may in fact not have any efficacy at all against this particular virus. So thank you. The other issue is you have to have the same blood type, or you have